This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to Friday Morning Fellows Conference. As you can see on the screen, our speaker this morning is Dr. Colby Shanafelt, one of our second-year clinical track fellows. Colby is a Pittsburgh native, did his undergraduate studies at Duke University, medical school at Temple, and then his residency at the BI in Boston. And he is going to talk about spontaneous coronary artery dissection this morning. So take it away, Colby.
Thank you, Dr. Williams, for the introduction. So for those of you that I haven't met, again, my name is Colby Shanafelt, second-year clinical fellow here at Emory. Thank you for taking the time out this morning to join me here, and I'm excited to get the year started with our obligatory annual talk on SCAD this year. So we'll go ahead and get started. Starting off with the case. We have a 49-year-old female, the history of hypertension, prior NSTEMI back in 2012, reportedly secondary to SCAD, who came into the ED after experiencing sudden onset chest pain that did radiate down her left arm while she was at work. Vitals pretty normal on arrival. Her chemistry panel notable for K that was mildly low, creatinine that was normal, and her initial high sensitivity troponin was 28, which uptrended to 134, and then subsequently up to 502. She's given a full dose aspirin. She's given sublingual nitroglycerin, which improved her chest pain, though she still notes this ongoing left arm pain. And then as she begins to endure some back pain later on as well. EKG, not the most remarkable, some borderline ST depressions and 3 AVF, V3, but no other signs of ischemia. So again, with this back pain that she has, and then also with some risk factors for PE, they do a CTA chest, abdomen, and pelvis down in the ED, which is normal, no aortic dissection, no evidence of PE. Her high sensitivity troponin continues uptrend, 502 up to 1268, gets to a peak of 6,900, at which point she's still noting ongoing mild chest discomfort, still with this arm and back pain. So heparin drip has started. She's actually given Flexeril, diclofenac, and a lidocaine patch for her back pain, which seems to improve her symptoms. The next morning, she gets an echo. EF is preserved, really unremarkable aside from some mild valvular abnormalities. And then I'll let this play through just a couple times here. But you know, this isn't the greatest image, but we do see this as a more of an REO cranial view. We can see that of the circ, there's this diffuse narrowing, also kind of extending into the OM that's consistent with SCAD. So for this case, you know, again, I think this is a really interesting area, a really interesting subject to investigate because there's a lot of diagnostic uncertainty and the management also isn't streamlined. So the learning objectives would be to learn how to diagnose and recognize the various types of SCAD, contrast indications for conservative management of SCAD versus PCI, as highlighted by 2 clinical cases I'll go through, discussing evidence-based management of SCAD, and then also looking into the screening intervals or the appropriate screening for other associated conditions with SCAD. So spontaneous coronary artery dissection, or SCAD, is that which is not attributed to atherosclerosis, trauma, instrumentation, ultimately leading to coronary artery obstruction due to formation of an intramural hematoma or intimal disruption, as opposed to the atherosclerotic plaque rupture or intraluminal thrombus that we're more commonly witnessing in patients with ACS. Overall, it's not the most common, obviously, cause of ACS, between 1% and 4%, although, and looking back at a lot of these older studies, at the time data was published, there really wasn't as much awareness or recognition as the various types of SCAD. So this number overall is likely underestimated, and this is definitely a diagnosis that goes under-recognized and is often also frequently misdiagnosed. Obviously, as we know, SCAD is much more common in women. This is meta-analysis, anywhere between 74 up to 100% of patients were women. And we do see that it tends to be a very common cause of ACS in women less than 50 years of age, anywhere from 8.7 up to as high as 35%. So having a high clinical index of suspicion based off of our patient populations, I think, is really paramount in these patients. Another interesting thing I came across, that only about 60% of female patients with ACS actually undergo coronary angiography. Again, leading to the fact that this is likely a underdiagnosed etiology of chest pain in our female patients. We says that this is the cause in up to 35% of MIs in younger women. It's the most common cause of pregnancy-associated MI, being about 43%. So I think these are the two things that usually key us in: pregnancy and younger female patients. The average age tends to be between 45 and 53 years old, but men do tend to present slightly earlier in age than women. And there's a preponderance of Caucasian women that are primarily affected. This is a prospective study that, again, looked at patients. There's 327 patients with SCAD. We see that the mean age pretty similar to what was replicated elsewhere, 52 and a half years old. Of these 327 patients, 90% were female, and 82% of those patients were Caucasian. Some of the other risk factors we look into that I'll get into later on. When we think about the predisposing factors, intense exercise, intense Valsalva, whether that's retching, vomiting, bowel movements, oftentimes a history is given of lifting heavy objects prior to the onset of chest pain. Intense emotional stress tends to be a big player. We've obviously talked about pregnancy, with the most common timeline for cases being immediately postpartum or in the labor and delivery process. Recreational drugs, cocaine, methamphetamines, and then there's also a role of exogenous hormones or hormone modulators, which also plays into why patients in the pregnancy period or peri-pregnancy period tend to have an increased risk of SCAD. Many associated conditions, the one we most commonly recognize is fibromuscular dysplasia, or FMD. We talked about pregnancy, multiparity. There are many inherited arteriopathies, connective tissue disorders, as well as other associations with systemic inflammatory diseases, which we will get into a little bit later on. Exogenous hormones, we've mentioned, association with migraine headaches, coronary artery spasm, and also hypothyroidism. Hypothyroidism seems to really be able to do anything. Clinically, these patients, present similar to other patients with ACS, which is why this diagnosis can be very challenging. Present with chest pain, often radiates down the arm, frequently experience elevation in levels of cardiac enzymes, as our first patient did. Rarely do these patients present in a more florid shock-like picture with hemodynamic instability. Ventricular arrhythmias or sudden cardiac death are much more rare, but do account for about 3 to 11% of cases. And then there's some variability with the incidence of ST elevation and non-ST segment elevation MI. EF is often preserved in these patients, as we also saw with our first patient here. So we talked about the definition of SCAD, this formation of an intramural hematoma or intimal disruption, in contrast to atherosclerotic plaque rupture. The way we classify SCAD is based off of the SAW classification. Jackie SAW is someone who's active in research over in Vancouver, who kind of came up with this classification scheme. It's angiographic characteristics that we look through. There are 3 types. Type 1 is this pathognomonic contrast dye staining of the arterial wall with multiple radiolucent lumens, either with or without the presence of dye hang-up or slow contrast clearing. I think it can be one of the easiest to recognize. Type 2 SCAD is our most common angiographically. It has this more diffuse and long, smooth stenosis that can vary in size from mild stenosis to complete occlusion. I think one of the things to highlight here is that these lesions are typically over 20 millimeters in length, and type 2 is further delineated between type 2A and type 2B, the former which does not involve the angiographic tip, and type 2B extending to the tip of the vessel. And then Type 3, I think, is the most challenging diagnosis to make, which actually owes to the fact that it mimics atherosclerotic heart disease. There's going to be focal or tubular stenosis, and this often requires the assistance of intracoronary imaging to further help differentiate the case from atherosclerosis. This is a nice picture, again, just for some of the things we look out for in SCAD. Again, in type 1, we have these multiple radiolucent lumens, contrast dye staining that we can see here. Type 2 being this long and diffuse smooth narrowing that looks pretty similar to that first patient I presented on the angiogram. And then type 3, again, mimicking atherosclerotic heart disease with this focal or tubular stenosis that I think is diagnostically the most challenging. As far as the pathogenesis of SCAD, there have been 2 primary events hypothesized, either the development of an intimal tear or a spontaneous hemorrhage that arise from the vasa vasorum within the vessel wall. We get separation that occurs in the outer third of the tunica media and formation of an intramural hematoma that tends to occupy the dissection and then compress the true lumen, leading to coronary insufficiency and myocardial ischemia. This is a nice diagram here. Again, a normal coronary artery in frame A, where you can see the true lumen with the 3 layers being the tunica intima, media, and adventitia. In panel B, we see formation of an intramural hematoma that's compressing our true lumen. And then in panel C, we see this intimal tear, where spontaneous, where SCAD is characterized by the spontaneous formation of this intramural hematoma, again, leading to compression and infarction if an intimal tear is present. Histologically and pathologically, in panel A here, again, we see this false lumen that's significantly compressing our true lumen. You can kind of appreciate here that there's a preponderance of eosinophils, which in the periadventitial space, which many people have thought to be pathognomonic for SCAD. Although that being said, eosinophilia in the adventitia is also a non-specific response to vascular injury. And then pathologically, again, we can see this compression of the true lumen by the false lumen here. So we talked about these primary events. This is in contrast to atherosclerosis, which is typically limited in extent, primarily by medial atrophy and scarring. And when we have non-atherosclerotic SCAD, one of the other proposed mechanisms or risk factors for this is due to arterial fragility, often in the setting of high concomitant rates of predisposing arteriopathies. There can be these very extensive dissection lengths that can make PCI very challenging. There's a role of coronary tortuosity as a predisposing factor that may contribute to the pathogenesis of SCAD, which we'll get into again later on. And then the association with pregnancy, and it's thought that these estrogen and progesterone surges during pregnancy can cause medial degeneration of the arterial wall due to either decreased collagen synthesis, increased mucopolysaccharide content, which is ultimately going to cause weakening of the vessel wall and predispose to dissection. Diagnostically, I think this is something that I think is very challenging, and especially from a fellow standpoint, I think is very easy to miss when we're in the cath lab. But I think, again, having the heightened clinical suspicion based off of the type of patient that's presenting, and then thinking about where the vessels are that are most commonly implicated in SCAD. So the LAD tends to be the most commonly affected. This is, again, that same prospective analysis found that the LAD accounted for 45% of cases. Other studies have shown rates as high as 61%. The circ and the ramus are less commonly affected, and the left main is very rarely affected, and 4%, up to 4% of cases in this study, only about 0.6% of cases were with left main SCAD. And then also, again, keying in on where SCAD most commonly occurs, I think can be helpful when trying to make this diagnosis. Typically occurs in the mid to distal segments, and less than 10% of cases actually involve the proximal vessels. Multi-vessel SCAD is also uncommon, anywhere between I guess as high as 23%, but usually it's involving just one main vessel. And then we mentioned again that type 2 SCAD is the most common angiographically. In this study, about 70% of cases, which is consistent with other reports. Diagnostically, I think as we've gotten a lot more comfortable with coronary CTA, we've started to use this in the appropriate clinical context, coronary angiography, and then the supplemental role of intracoronary imaging. So with coronary CTA, I like this diagram. I think it does a nice job of looking at some of the CT features of SCAD. So in panel A here, we see this tapered luminal stenosis, and B, abrupt luminal narrowing. In panel C, we can see luminal occlusion, D, formation of this intramural hematoma that's compressing our true lumen. E, we have a formation of a dissection flap, and then subsequently this intimal hematoma that forms, intramural hematoma that forms. F, this can be challenging to appreciate, but especially on CT, this is one of the key findings, is looking at perivascular fat stranding, which I have a couple examples of. We talked about the role of tortuosity of the coronary arteries and the predisposing conditions of anatomy of the development of SCAD, myocardial bridging, and then we'll touch on this more later, but also using CTA to look for other associated conditions with FMD, with aneurysmal dilatation and this beating appearance. So this is a 35-year-old female who had presented with chest pain, and these are two images here, CT on the left and coronary angiography on the right, and we see this tapered, smooth narrowing of the distal LAD that's also seen on coronary angiography here. Again, more consistent with a type 2 SCAD. This next case is a 42-year-old female who came in with a prior history of an apical infarct. She came in with chest pain and then has this irregular tapered severe narrowing of the proximal PDA. And with the 3D reconstruction, you can see here this abrupt narrowing, again, more consistent with a type 2 SCAD. I think this is a really nice picture here to go through, just contrasting, again, the diagnostic challenges between atherosclerotic coronary artery disease and SCAD. So in the panel on the left here, we see this abrupt severe narrowing of the distal LAD, and notably really can't appreciate any coronary calcium. There is some tortuosity of the LAD here, and as we kind of blow this up, and it can be, I think, a little bit challenging to appreciate on here, there is some perivascular fat stranding. Whereas in panel B, we also see this abrupt severe luminal narrowing, but it's more of the proximal LAD. And as we zoom in, you can see some non-calcified plaque at the level of stenosis, which would favor atherosclerotic coronary artery disease. One of the challenges in trying to rely on this is that non-calcified plaques can mimic intramural hematomas. So again, just another wrench into the diagnostic challenge here for these patients. So thinking about the role of coronary CTA, it's not recommended as first-line imaging for acute suspected SCAD, often owing to the lower spatial temporal resolution compared to coronary angiography. We know that SCAD tends to occur in the mid to distal vessels, and the spatial resolution is further limited in these areas, which limits specificity, especially also looking at visualization of smaller caliber arteries, especially as we get more distal. There's poor visualization in less than 2.5 millimeters. SCAD often occurs without intimal disruption, so contrast may not actually identify the false lumen, and medial hemorrhage without intimal rupture may be easily missed. I think that some of the role where coronary CTA may be most helpful is in follow-up, especially if we have dissections in proximal or large caliber coronary arteries. I think this is a reasonable option for conservatively managed SCAD to monitor the healing in these patients. This is a meta-analysis that again looked at the use of CT angiography on SCAD, and a couple things to highlight through here. Again, it talks about some of the pertinent features of SCAD being abrupt luminal stenosis, intramural hematoma, tapered luminal stenosis and dissection, thinking about this perivascular fat stranding, and then also talking about this distinct feature being this diffuse luminal narrowing with a sleeve-like wall thickening. that can kind of help further, again, delineate SCAD from atherosclerotic coronary artery disease. They showed that CCTA at 3 to 6 months was able to show complete healing in SCAD of up to 83% of patients at the 20-month follow-up period. And again, I think as we're getting more comfortable with coronary CTA, it may aid more in the future with diagnosis, but SCAD may be missed on coronary CTA in patients who present with signs and symptoms of ACS. So really, coronary angiography should be our gold standard for making this diagnosis. A couple of images here. So again, type A, I think, can be a little bit easier to recognize, where we have these multiple radiolucent lumens or arterial wall contrast staining. In panel B, we have more of this diffuse stenosis that can be of varying length and severity. Type 3, again, you can, even looking at this can be challenging to make that diagnosis, especially, again, obviously from the fellow standpoint of view. But we see this focal or tubular stenosis that's usually less than 20 millimeters in length compared to the longer lesions that we see most commonly in type 2 SCAD. And here again, mimicking atherosclerosis, this has required the use of additional imaging with intracoronary imaging to be able to confirm the presence of an intramural hematoma here, or multiple lumens. This is an OCT image, so we'll talk about intracoronary imaging a little bit later on. So coronary angiography, again, the gold standard for diagnosis of SCAD. We've talked that type 2 being the most common, around 67 to 70% of cases. Again, I think kind of relying on these multiple lumens or contrast dye staining that we see in type 1, while this can be easier to see, it only occurs in about 30% of cases. So just relying on this would cause us to miss 70% of diagnoses. Coronary angiography is also not without its own risks. There's a higher rate of iatrogenic induced dissection, up to 3.4% compared to less than 0.2% for standard coronary angiography. And this is thought to really be due to, again, this arterial fragility that's likely predisposed by concomitant arteriopathies. For intracoronary imaging, the main role is, I think, as an adjunct, primarily when there's diagnostic uncertainty, with type 3 SCAD being able to actually visualize that intramural hematoma. And there's two main types of intracoronary imaging that we utilize. The first being intravascular ultrasonography, or IVUS, and the second being OCT. So IVUS has very good spatial resolution. It's going to be able to detect intimal tears, looking at false lumens, intramural hematomas, intraluminal thrombi. OCT actually has a little bit better spatial resolution than IVUS, and when it is available, it tends to be the preferred method. So this is a couple of pictures, OCT and IVUS. In panel A here, we see this intimal dissection and an intramural hematoma that's formed. And then in panel B, again, IVUS showing this formation of the intramural hematoma that's compressing our true lumen. Just another image blown up of OCT, where we can again see our intimal dissection and then this large intramural hematoma that's compressing our lumen. Intracoronary imaging, while it can be useful to help make this diagnosis, it's also not without its own risks. There is a risk of propagating the coronary dissection, further risk of iatrogenic dissection, risk of catheter-induced occlusion of the true lumen, and then also solely to OCT, a risk of hydraulic extension as we inject contrast with these patients. So Dr. Jabber was really helpful in the formation of this talk, and these are some cases that him and I had gone through before. Dr. Jabber, if you were going to make it this morning, in light of the risks of intracoronary imaging, do you find yourself incorporating IVUS or OCT into your practice when making these diagnoses?
Thanks, Colby. Nice talk. It has plus and minuses. Most of the time, we try to avoid to manipulate these vessels. Most of the time, the index of suspicion is high enough. We have a young female with tortuous vessels and coming in with an non-STEMI, and what looks like a coronary dissection, and we just use that as a diagnosis. I would say maybe less than 10% of the cases we have to do intravascular ultrasound to discern these, especially in the type 1 and type 3 lesions. We're always worried that when we're wiring the vessels, we could wire the false lumen and cause worse dissection, which is probably not going to happen. I mean, usually we're good at wiring the true lumen, but we try to minimize instrumentation of these vessels in general.
Thank you very much. So I think this is a nice, algorithm for the diagnosis of SCAD that we can use. Again, having this high clinical index of suspicion that you mentioned, Dr. Jabber, thinking about the role of early coronary angiography, looking at, again, if we can recognize this type 1 SCAD pattern with this arterial wall stain, yes, we can make our diagnosis. But when we have, type 2 SCAD or type 3 SCAD, possibly using intracoronary imaging as an adjunctive tool. And I think I'd like to spend the second half of this talk, which I think is actually the most interesting part of SCAD, is how we actually manage these patients. So as many of you know, we usually tend to opt for a more conservative management strategy, knowing that SCAD tends to heal angiographically in the majority of patients, between 73 and up to 97% in a short period of time, just within about 4 to 6 weeks. This was an observational study of 131 patients who had repeat angiography, and nearly 90% had documented spontaneous healing of SCAD. We talked about the fact that lesions are most commonly affecting those in the distal segments, which may be too small or too distal for stent implantation. These very long lesions, with, again, type 2 SCAD being the most common, usually longer than 20 millimeters in length, would often require multiple stents. There are risks, obviously, of PCI, an increased risk of complications. The affected coronary arteries, we've said already, may be weaker just due to these underlying arteriopathies, and thus more susceptible to iatrogenic dissections and extension of the dissection with PCI. Thinking about coronary guide wires, like you'd mentioned, Dr. Jabber, entering the false lumen, potentially occluding the true lumen, with balloon dilatation or stent placement, possibly extending the dissection or propagating that intramural hematoma either upstream or downstream to cause worsening vessel obstruction. And I think a big thing with this too is that we discussed how these intramural hematomas tend to resolve over time. Because of this, if we put stents in, this can result in late stent strut malapposition, which can increase the future risk of stent thrombosis. This is a study, a retrospective analysis of 189 patients with SCAD, and found that the procedure failure rate in patients who were revascularized was about 53%. This was often attributable to technical failure, either wire entry into the false lumen, final loss of flow after stent placement, or significant residual stenosis. I think this is interesting that the mean number of stents deployed had to be 2.4 stents, with the mean stented length being 44 millimeters, many of which had residual stenosis greater than 50%. While the numbers were low here, there were 13 patients in the revascularization group that actually required emergent CABG, compared to only 2 patients in the medically managed group. And then looking at long-term 5-year outcomes, we see that there's really no difference in the revascularization versus conservative approach for these patients. Other studies, again, have looked at this in this prospective cohort that we touched on earlier. About 16% of patients were treated with PCI with a similar 56.9% procedure failure rate. There's an Italian study that looked at 134 patients with SCAD and did have a slightly higher procedural success rate. Although in that study, up to 72 months, there was a higher rate of major adverse cardiovascular events in the PCI group, with a higher need for repeat revascularization. So again, a very challenging strategy with these patients. That being said, there are some patients in whom revascularization may be appropriate. Those who have these high-risk features of left main coronary artery dissection, again, only accounting for about 4% of cases. Patients with ongoing ischemia, TIMI grade 0-1 flow in a proximal vessel, again, this being an uncommon location. Those who have hemodynamic instability or refractory arrhythmias. And I think it's also important to kind of think about what our actual goals are for revascularization. I mean, in ACS, the goal with PCI is to restore flow to TIMI grade 3 with a residual stenosis of 20% or less, whereas the goal of SCAD is to improve our baseline TIMI flow by 1 grade, or to obtain or achieve TIMI grade 2 or 3 flow and reduce the residual stenosis by just less than 50%. Again, knowing that these vessels tend to heal on their own. This is another case that I came across and actually was involved in from the EP side of things. This is a 49-year-old healthy female. She's a marathon runner who presented to an outside hospital with chest pain. She's found to have an anterior STEMI. Shortly thereafter has 2 episodes of polymorphic VT arrest. She's shocked with ROSC, and then she's stabilized and she's taken for emergent coronary angiogram. I'll let these images just play through a couple of times before we go through them. But we can kind of make out that in this image, it may be kind of hard for you guys to see, but she does have this contrast staining with these multiple radiolucent lumens in her left main, and we're obviously missing her LAD. So she has SCAD of the left main with 100% proximal LAD occlusion. She has a balloon pump placed at the outside hospital. She subsequently deteriorates overnight, and she's taken to the OR for emergent impella placement, but her vascular anatomy is really not amenable to placement. She ultimately gets cannulated for VA ECMO. She's maintained on multiple pressures, and she's transferred to EUH, where she quickly undergoes axillary impella placement. So this is obviously a more extreme case of SCAD. This patient was obviously, again, not revascularized at the outside hospital, but given her severe clinical presentation, her high-risk features with her anatomy, Dr. Jabber, is this someone that you think that you would have considered revascularizing? I know, again, she came from the outside hospital.
Yes, but when she first presented, this is one of the few indications where intervention is beneficial for the patient. She was having arrest, she was having ST elevations. You totally lost the LAD. If she had any flow in the LAD, I would have left it alone. But with the presentation, you need to do something urgently. She could lose her anterior wall. The operator, I think, in this case was very uncomfortable intervening on the LAD. The place did not have surgical backup, so it makes sense to do something else. But these are cases you want to intervene on. Otherwise, in the majority of cases, you really want to resist a lot putting any stent in these people.
Yeah, thank you very much. So, there was also some discussion about bypass surgery. There's really limited data available with this. Again, possibly being effective for patients with left main or proximal dissections. We talked about this as part of a rescue approach from attempted PCI, patients with refractory ischemia. But I think it's important to note that CABG is not protective against recurrent SCAD, and these grafts tend to have a very high rate of failure, even at just 3 years. And then, obviously she required a lot of mechanical circulatory support, which is, again, usually considered in accordance with normal guidelines for ACS. But there is a word of caution with balloon pump placement, impella, ECMO, just due to these higher rates of concomitant arteriopathies, where these large bore catheters may result in iatrogenic dissection of either the iliac arteries or the aorta. And kind of fittingly with her, as her case continued to matriculate, you can see here that she has an intimal tear in the distal aortic arch with an associated intramural hematoma. So whether that was from ECMO cannulation or balloon pump, but just something to also be aware of, if these patients do require mechanical support. And then Dr. Jabber, as you mentioned, the most common type of management for these patients is medically. And I think this is also very interesting, especially thinking about the role of antiplatelet therapy. So aspirin, we generally recommend use for at least 1 year and frequently indefinitely, but a lot of the kind of conflicting data or the lack of clarity with this, I think, is the role of DAPT in these patients. So we think about minimizing the risk of thrombus formation secondary to intimal dissection versus possibly worsening medial hemorrhage with an aggressive antiplatelet therapeutic approach. This is an Italian study that investigated the 1-year outcome of patients with SCAD. who were managed with conservative treatment versus PCI. And then among those patients who were treated conservatively, they were grouped into whether or not they received single antiplatelet therapy versus dual antiplatelet therapy, with the primary endpoint being 12-month incidence of major adverse cardiovascular events, including all-cause death, non-fatal MI, unplanned PCI. And in this study, 199 out of 314 patients were managed conservatively, and 66% of those patients were treated with dual antiplatelet therapy, either aspirin and Plavix or aspirin and ticagrelor, compared to single antiplatelet therapy. And we see here that the overall MACE rate was significantly higher in those patients that were treated with DAP, 19% compared to 6%. And this was largely owing to an increased risk of recurrent MI or need for urgent PCI. So the independent predictors of MACE at 12 months follow-up, again, being dual antiplatelet therapy and also increased risk of patients who had type 2A SCAD specifically. So, I think the overall data for including a second antiplatelet agent, outside of patients obviously who undergo revascularization is of uncertain benefit. I mean, there's been, recommendations for DAP for up to 4 weeks, for 3 months, 3 to 6 months, DAP for a year. But we don't have a lot of great studies underway. There's one that's currently enrolling. It's the BA SCAD trial, trying to identify differences between 1 month of an antiplatelet regimen compared to 12 months of DAP. And, Dr. Jabber, this is something, for the first case that you and I were involved in, we talked about a possible recommendation for dual antiplatelet therapy. But, I'm curious to see what your framework is overall for recommending DAP for these patients. Are you doing more single antiplatelet therapy?
We don't know, Colby. I mean, as you mentioned here, the data is not a prospective or randomized data so far, but we will see some results down the road as more data comes in from registries and trials. It makes sense to just keep people on single antiplatelet. Mind you that even in coronary stenting, we're moving more and more towards single antiplatelet with a non-aspirin medication. It seems that the combination of dual antiplatelet therapy is everybody. It increases risk of bleeding with less, with not much more protection in terms of coronary events. So maybe it's the same thing for this population. And single antiplatelet with a non-aspirin agent would be better.
Thank you. Anticoagulation, again, these patients presenting with ACS, so this is often initiated as part of the initial management, but once the diagnosis is established, there's really no clear benefit to continuing anticoagulation. The European Society of Cardiology recommends that anticoagulants be stopped upon confirmation in the absence of another compelling reason. Again, I think with this theoretical risk of increased intramural bleeding, though there still is a positive evidence with this. And then thrombolytics are contraindicated given concern of propagating the dissection or leading to coronary rupture or cardiac tamponade. Beta blockers seem to have conferred the best benefit and the best evidence. This is, again, that trial of 327 patients who were followed prospectively with SCAD. In this multivariate analysis, only beta blockers used to diminish the risk of recurrent SCAD, and it reduced the risk by nearly 2/3. So a lot of good data for beta blockers in these patients. I think we kind of think about a role, similarly with aortic dissection, where we use beta blockers in that acute period and then long-term, but trying to reduce myocardial contractility and blood pressure to further reduce arterial wall stress to protect against future dissection. And then also thinking about just the role of these, intensive motion, exercise, these catecholamine surges, also trying to potentially mitigate that effect. Statins, I think a lot of this came out of this trial in 2012 that looked at 87 patients and found that there may be an increased risk or association of statin use with risk of recurrence. But this was pretty limited by a small sample size, inconsistent statin use, and not replicated in larger studies. But I think even beyond that, knowing that SCAD is actually not an atherosclerotic event, and understanding that pathophysiology, there's really no reason to put these patients on a statin outside of a, guideline approach for its requirement for lipid-lowering therapy. Given association with pregnancy and these presumed relationships with female sex hormones, exogenous hormone therapy, whether that's OCPs or postmenopausal therapy, is generally avoided if possible. Though again, there's no direct evidence with this. Unfortunately, recurrence is quite common in these patients, with a recurrence rate of anywhere between 10% over 3.1 years, and other studies have seen recurrence rates as high as 27%. When we think about recurrence, I think it's important to think about how we're actually defining recurrent SCAD, whether that's either the extension of the dissection from expansion of the intramural hematoma, or thinking about more commonly a de novo dissection that usually occurs more than 30 days later. The artery, that's initially implicated usually is not affected again. So these tend to recur in unaffected arteries at least 3/4 of the time. And then thinking about other risks for recurrence, hypertension seems to confer one of the highest risks for recurrence in these patients. So I think getting very adequate blood pressure control is of paramount importance. I mentioned this earlier on, as far as coronary artery tortuosity. This is a study that had looked about assigning a tortuosity score in these patients, and found that those patients who had a lot of tortuosity showed a trend towards a higher rate or higher risk of recurrence, although this wasn't statistically significant over a 5-year period. These patients present with recurrent chest pain. Unfortunately, 20% of patients with SCAD tend to be readmitted within 30 days. And again, this is where coronary CTA may come into play. Other types of imaging modalities, CMR, PET stress, may be used. Looking through this too, in the absence of symptoms, I really didn't come across anything that talks about routine or standardized follow-up imaging for these patients, whether that's coronary angiography, coronary CTA. So I think in the absence of clinical symptoms, we're not usually routinely getting coronary CTAs to monitor for improvement. But again, this may be documented as early as 4 to 6 weeks afterwards. We've discussed the association with pregnancy. So subsequent pregnancy is generally not recommended in these patients. I think this is very challenging because we've already said that birth control options are also limited, secondary to these hormonal interactions. So balancing, trying to prevent recurrent pregnancy, but also not having a lot of good options for birth control strategies. Pregnancy-associated SCAD, which accounts for about 43% of cases, these patients do tend to have worse outcomes. So should patients elect pregnancy or become pregnant, they should really be followed by a multidisciplinary team, including cardiology and MFM. I think this kind of came to light later on as I was preparing this talk and thinking about, our second patient, marathon runner, and we tend to have kind of similar, backgrounds of these patients, and thinking about what do we tell them afterwards when, their whole life gets uprooted, especially her, about someone who loved to run marathons and now have this very traumatic event. What do we recommend as far as exercise? So there's some questions involving activity restriction. Some of the guidelines have talked about or recommended avoiding lifting more than 10 pounds. There's been some hesitancy with pursuing activity beyond limited walking. But again, trying to balance, the risk of inducing a sedentary lifestyle. I think a lot of these weightlifting limits and heart rate targets tend to be pretty arbitrary. Cardiac rehab is very important in these patients. To assess any exercise-induced symptoms, provide immediate feedback on exercise hemodynamics, and individualize any fitness needs. There's been this Vancouver General Hospital SCAD program where they look at, getting a blood pressure no higher than 130/80, with a heart rate between 50 and 70% of the heart rate reserve, talking about free weights for resistance training between 2 and 12 pounds, starting low and then gradually increasing. But I think in general, avoiding any prolonged high intensity exercise, competitive or contact sports activities performed. Those are performed to exhaustion. Thinking about limitations and abrupt increases in physical activity without a warm-up phase, extremes of temperature, that's things like hot yoga or exercising in cold weather or extreme terrains, and then trying to limit Valsalva during lifting or exercise. Generally, it's been shown that resistance up to 20 pounds in women and 50 pounds in men has been shown to be safe. But again, I think taking these, gradually. And then just to conclude here, the screening for associated conditions, obviously we know that FMD tends to be the most common association with SCAD, anywhere between 25 and 85%. This study again found that FMD was diagnosed in 62% of patients. The renal, carotid, and vertebral arteries tend to be most commonly affected, and vascular imaging is recommended in all of these patients from brain to pelvis, either with a CTA or an MRA of the head, neck, abdomen, and pelvis. I actually had a patient in my clinic a few weeks back who had a history of SCAD a couple years back and hadn't had any imaging. So again, I think if you see these patients and they haven't had this, head to toe imaging, this is definitely something we should be ordering to make sure there's no other associations with FMD or any other signs of vasculopathies. So I think from med school, we all kind of remember this string of beads appearance with multifocal FMD. In frame A, we see a selective angiography of the right renal artery. In B, we see this aneurysmal dilatation of the carotid artery. And this is a CT again of the renal arteries, which shows aneurysmal dilatation as well. Some of the other arteriopathies that we mentioned, Marfan's, Loeys Dietz, vascular Ehlers-Danlos, alpha-1 antitrypsin, and polycystic kidney disease. Generally not screening for these in the absence of a heightened clinical suspicion, family history. Patients have asked about the role for genetic testing, which is currently not advised. Obviously, when there are findings that are suggestive of an inherited disorder, sequencing of a panel of genes to kind of include a lot of these inherited arteriopathies should be considered. And this is a panel here of some of the genes that have been implicated. So then just to kind of finish up and revisit our cases. So in case 1, we have SCAD of the CIRRC OM1 type 2A with 50 to 60% vessel stenosis. She is managed conservatively. She started on a beta blocker. Again, there's a discussion regarding DAPT for 3 to 6 months, but as that discussion progresses, we ultimately discharge her on single antiplatelet therapy with aspirin monotherapy. She has no indication for a statin, and she does get head-to-toe imaging that it's negative for any concerning vasculopathies or FMD. And then case 2, again, our left main SCAD and total occlusion of a prox LAD. Very fortunately for her, I think the cat was somewhat out of the bag already by the time she got transferred to EUH, but she's, in the ICU. She's able to be weaned from ECMO and Impella. She gets decannulated and Impella is removed. She does have a reduced EF. So she's put on guideline-directed medical therapy, started on a beta blocker, aspirin monotherapy. She's also put on a statin, although, again, based off of what we discussed, really didn't really have an indication for a statin, but she's discharged on one. I think she was seen in clinic not too long ago and has been doing well. So again, I think SCAD is a very interesting area, just again, owing to the diagnostic challenges and thinking about how a lot of these guidelines for, when we predominantly manage these patients conservatively aren't very well established. So I'd like to thank Dr. Jabber, really appreciate your guidance and expertise with this, Dr. Clements as well for their assistance with the creation of this talk. And I am happy to take any questions at this time. Thank you very much.
Thank you, Colby. Good review. Yeah, I guess I enjoyed the part about CTA in this, and it's something that's come up from time to time. I guess one question from that review article on CTA, did they discuss like sort of the relative if it's known, the relative sensitivity, specificity of CTA imaging versus coronary angiography in the cath lab for detecting or differentiating SCAD from more traditional causes in this group. So, like, for example, since this is if it's a young woman, that the clinical suspicion is high before you even take them to the cath lab that this is SCAD, minimal risk factors and an NSTEMI and not someone you're, loath to intervene on anyway. Are we better off doing a CTA if there is, better imaging, specificity, and also you can potentially image other vascular beds, as you mentioned, which is, can be important in this group.
Yeah, absolutely. That study was a retrospective analysis, and they were not blinded to the patient diagnoses, so they weren't able to assess the sensitivity or specificity for detecting SCAD. But I think that, again, just owing to some of those limitations, and again, with also these patients, they're also tending to present with an elevated troponin, having consistent chest pain. So I think that early coronary angiography is really the best bet for these patients.
Colby, Stan Sherman. The second patient, how about LV function after all that with a total occluded artery?
Yeah, so her EF was low. I think it was around 25 to 30% whenever this kind of happened. She hung out there. She was actually evaluated. I think a lot of people in the hospital knew about her, but she was evaluated by the advanced heart failure team, and there was some consideration of VAD or transplant for her. But again, she got better, relatively quickly. I have to kind of see, what overall they're thinking now in terms of follow-up, but that was a consideration. I mean, her EF was very low, and she was really sick. So hopefully her EF will recover, as these vessels heal on their own. But again, it kind of remains to be seen at this point.
Colby, Steve Clements.
Sir.
That was very, very good. Would you go back to that beautiful slide that had the coronary arteries from the chin shot?
For the left main SCAD?
The diagram way early.
Oh, okay.
But anyway, I hate to think of how many you've tested. I hate to think of how many of these that we all have missed, and I have missed in the past. And if you miss them, if they're like type 3, if you miss them and they go out the door and then they come back to your office 2 or 3 or 4 or 5 months later, they say, well, what caused that chest pain? You say, well, I don't know. Of course, they have healed all this up and the follow-up is good. And if you looked at it angiographically, then it would be all right. And you missed it, but you came out all right. So I'm sure that others have the same feeling. But everything you say about an index of suspicion for SCAD is important, and looking for those kind of findings of distal, diffuse narrowing, and are important findings when you don't have an obvious intimal dissection that you can identify. So I think all of our radar screens and antennae are up, watching out for this as time goes on in the setting of a young person, a woman or man, who has slight troponin rise and a chest pain syndrome. So thanks for teaching me a lot, and that was a great presentation. I liked your illustrations.
Thank you. Appreciate it. I think one of the other things I was thinking too is that, patients who have these arteriopathies, haven't had SCAD, have FMD or other connective tissue disorder, I think it's another, a reason for that antenna to go off. And, obviously not screening them in the absence of any symptoms, but for the patient with FMD or with Marfan's or, Ehlers-Danlos who develops chest pain, obviously really having a high suspicion for SCAD.
Colby, with some here, excellent talk and very important comment from Dr. Clements. The most common, when we talk about sensitivity and specificity of all these tests, CTA and coronaries, we're assuming that somebody really knows what they're doing and they're actually looking for these things on the coronary angiograms. For people who are not going to be interventional and invasive, when you send somebody to the cath lab and they tell you the coronaries are normal, if you still think something is iffy, you need to look at these with the invasive person. The most common mistake I see in these people in the cath lab is missing the diagnosis. Usually happens in type 2B, where you have diffuse distal disease in the vessel, very distal LAD or diagonals or obtuse marginals. I've seen these a lot. The second common mistake is the type 3, where you see patients stented thinking that it's atherosclerosis. And sometimes they leave the hospital thinking that it has been coronary disease, average coronary disease, and you see them in clinic later on with a stent, but no other disease at all, young women. So mistakes do happen in the lab, and you really need to be careful with these. We've become better since all this kind of SCAD registries and the movement and all the research. We've become better at looking for these on angiograms.
Thank you very much.
Okay, well, thank you again, Colby, for an excellent review, and thank you everybody for your comments. Thanks again. See everybody next week.
Thank you, everybody. Bye-bye.
The preceding program is copyrighted by Emory University.